Big changes could be coming to hospice care in America. The government is taking a hard look at how hospice is regulated and reimbursed, and the stakes couldn't be higher. Will these changes expand access to care or create new barriers for patients and providers? With millions of Americans relying on hospice each year, this isn't just a policy debate. It's about real families, real caregivers, and real lives. Let's break it down. Okay, so for our first segment, we're going to be talking about the hospice benefit. Just a small topic, but a lot that we can get into. I think we'll want to focus on, number one, what has the benefit done to date? How has it got us here? I know we talk about the hospice benefit as a huge success. So let's talk a little bit about why that is, how many people it's currently serving. And then let's explore the potential areas for reform that the Alliance is thinking about. There's a lot of different pathways to better the benefit, and I think we're at a critical turning point for our community right now in the hospice space. So we can't, solve all the problems today, but we can certainly start to talk about them, spark the conversation, and then of course come back to the Alliance for more information and updates on potential policy reforms. But let's back it up, get started with what's the hospice benefit? Why has it been so successful to date?
Elyssa, I'm so glad we're going to talk about hospice. It is, in my view, a national treasure. And I think any conversation about hospice, we're going to get into hospice reform and how to maybe improve the hospice program. But the first kind of the foundation of the conversation is the incredible impact that the hospice program has had on our country, on our healthcare system, on millions of patients and families. Okay, so we dial it back. 1982, we get a hospice benefit in the Medicare program for the first time, and now 40 years later, just over half of all Medicare beneficiaries are receiving hospice care at the time of death. And so it has become a central part of how the end of life is experienced for older and disabled Americans through Medicare. I tend to think of hospice, so when we think about Medicare, so when we talk about the hospice benefit, we're talking about the Medicare hospice benefit, okay? Medicare, going back 1965, President Lyndon Johnson signs the Medicare Act into law. And at the time, when President Johnson signs the Medicare law, he says that this law is intended to remind us that in a land bursting with abundance, that we should never forget those that are suffering.
For Mr. Truman, the passage of Medicare is a dream come true.
That the purpose is to relieve suffering and to address despair in many respects. And I think that really hospice has helped Medicare meet that founding mission of truly addressing the comprehensive needs of people on their hardest days, at their hardest times. So that benefit, that program, sometimes hospice, people think of hospice as quote unquote stopping care, okay? Hospice is about more care, not less, for people that need different type of care that's comfort oriented, that's comprehensive and holistic. So people become eligible for the hospice benefit when their prognosis, their survival prognosis, can be certified as 6 months or less if their illness runs the usual course, and also when they attest that their goals of care, that their goals of care are comfort rather than cure. And while receiving hospice care, people do forego their other Medicare benefits so that all their care for that terminal diagnosis is provided within the hospice benefit. And the care that's provided, it's patient-centered. It has developed a personalized care plan based on the specific needs of a person, everything from their family and social circumstances to their specific medical needs, the symptoms that they're having. Are they having pain or shortness of breath or confusion or even tailored to their psychological state or even faith-based considerations. So this is a person-centered model that's delivered by an interdisciplinary team. We have nursing is central to the hospice model, but certainly home health aides play a critical role in hospice care. Social workers, chaplains, even volunteers are a critical part of a hospice team. Physicians, we play a role in medical direction and medical oversight as well. So this is a comprehensive, person-centered, team-based model that is a national treasure. Okay, that this program, it does a great job at relieving suffering, improving quality of life at the end of life. We have studies across multiple diagnoses that when people receive hospice care, they get their symptoms addressed, their quality of life is improved, their caregiver experience is improved. And also, here's the thing that is not the rationale for hospice, but critically important when we're talking about health policy, is that in many, many care scenarios in hospice, the system saves money. So here we have this program. It is multidisciplinary, patient-centered. It is proven time and time again to relieve suffering, meet people's needs, saving the system money in many instances. This is, if we were to try to have this conversation about other types of care in our healthcare system, we would not hit on all these points.
Yeah.
Okay, hospice is special, and when we're going to talk more about reform and what needs to change in hospice, that has to be the jumping off point, in my opinion.
Couldn't agree more. And I think one way to talk about the success of the benefit so far is to see that over half of the eligible beneficiaries are receiving the benefit, and to say, wow, phenomenal progress. We've gotten half the population to die in hospice care with the support that they need and with the family caregivers getting the support that they need. But the glass half empty way of looking at it is that there's 50% of people that aren't accessing this really important benefit. And a lot of these reforms can help agitate that need for people and help them understand like why hospice would serve them, some of the barriers that people think get in the way of accessing hospice care having to do with the prognosis or even shorter length of stay. A lot of these things we can address with reform and also supporting the providers delivering that care so that they can continue to provide that interdisciplinary model that is so unique and special and successful in healthcare. So from a high level, I think one of the things that we want to talk about is continuing adequate reimbursement for hospice providers. We know it's no secret that there are constantly cuts happening right now in our government, and also just generally each year we're fighting to make sure that we have adequate reimbursement for providers. So far hospices have been able to see success, but why is it important that we continue to keep reimbursement at a level where providers can practice providing the very best care? What are we talking about when we're talking about the cap or Medicare sequestration? What are these things that are potentially getting in the way of providers being reimbursed at appropriate level for them to provide the care that's needed?
Elyssa, you touched on, I want to hit on one thing that you said first, and then we'll talk about reimbursement, was that getting access to hospice care earlier has life-changing benefits, and also that's where some of the system benefits and some of the savings and avoidable hospitalization and nursing home stays happen as well. And what we've seen is that the typical person using hospice, the median length of stay, if you will, has been 18 days, and it's really been stagnant for several years now. And it's not getting longer. And we would really like to see people getting into the benefit longer so that they can realize the potential impact it has. And certainly, so half of the people have 18 days or shorter length of stay, and there are many that are just receiving care for just a couple of days, even sometimes hours. And in fact, if people working in hospice and palliative care in America's hospitals, what they will tell you is that it is not uncommon that a reason that a person that's referred to a hospice doesn't get admitted to the hospice is because they died before they could even go through the enrollment process. So some people are being referred, if we counted those folks, the median length of stay would be even shorter because there are people that just aren't getting the care. So when we think about reimbursement, Medicare pays hospice providers, Medicare certified hospices, to deliver that comprehensive set of services. And also, in addition to the human services, hospice covers medications, medical equipment, supplies, wound care supplies, all the types of things that somebody might need for that type of care. But mostly it's people. Okay, mostly what hospices are bringing are the skill and love and compassion of expert caregivers. Okay, that's what it is. And when that reimbursement stagnates, then the agencies don't have the purchasing power in a very competitive labor market. Okay, we have shortages of nurses, shortages of home health aides. Hospices need to compete for talent with hospitals and other organizations. We've even seen a rise in sort of work from home jobs for some, from nurses and sort of telehealth and other things. It is a competitive labor market. And labor cost inflation in recent years has skyrocketed for all of healthcare, but particularly for hospices. And if we look back since 2019, if you look at hospice payments, that Medicare payments to hospices, they've basically been flat and even down a bit when you adjust for inflation. So the purchasing power that the hospices have to bring all that skill and support to the person's home, or if they're in a nursing facility, it's not kept up with the cost. And that can lead to lower quality care, less access to care, less intense care. So reimbursement is a critical issue. We've got to make sure that it's strong enough so that hospices can deliver what's needed.
Absolutely. And as we know right now, the hospice reimbursement model is that per diem model. So they're getting paid for the day that the patient is receiving care, but not necessarily for the amount of care that's delivered. And so you have all these different care team members going out to the home, and that's really unique in healthcare. So I think, making sure that we have the financial support to be able to continue that interdisciplinary care, and that we don't cut corners around spiritual support or psychosocial support is critical. Even bereavement support, that's crucial for the family. And I know so many hospices are even providing that support to the communities that they serve. On their own accord, like they're not getting paid for that, because they want to be a pillar of the community that folks can trust when they need them in their time of need after emergencies or anything like that. So there are so many reasons that we need to continue to invest in the hospice workforce, allow staff to compete with the payment that hospital staff are getting. And there are a lot of non-monetary reasons that providers want to work in hospice care, but they need to be adequately paid, of course.
Yeah, Elyssa, the payment and one of the things, you'll hear me say this a number of times in our conversations about our healthcare system is if you're not confused, you're not paying attention. And so, with some of the healthcare reimbursement models, you really have to zero in, because there's a lot of layers to it. With hospice, of course, we have a per diem payment model. It's different depending on the level of care. So routine home care is the most common type of hospice care provided, and that's at one per diem rate that the agencies are paid. There's also a general inpatient level of hospice care for people that need the level of care that can only be provided in a hospital or hospital-like setting. We have respite care. Right now, respite care is only in facility-based respite options for family caregivers. We talk about reform. Can't we have an at-home respite option? Family caregivers are under incredible stress. Just the transporting and the change of care venue is stressful. That's something we could improve upon. But right now, respite care is a facility-based respite. And then there's a continuous home care model as well, that for people that are at home that have more extensive needs, maybe their symptoms are changing fast, they need IV medications titrated at home, and that's a different level of payment. Payments, those per diem payments, are a bit higher at the start of hospice care, and then also with a service intensity increase at the end of care, at the end of life, and they go down in there. And listen, could we poke holes in this per diem model for hospice payment? Absolutely. You and I, having been in this for a while, we could talk about, what's wrong with it. If somebody has a very short length of stay, but a lot of needs, the hospice gets paid a couple per diem payments, and that's it. And how are they going to cover getting all that equipment out to the person's home and all that caregiving and all those resources for just, literally a few $100s? It just doesn't, the math doesn't work. And then on the other side of it, somebody that's in hospice for a long time, those per diem payments add up. The total payments the hospice can get quite high, and some critics might say, well, is that an overpayment or unnecessary? And I think all that is worth talking about and exploring. But I also I'm protective of hospice. I just see all the impact that it's having. And there are unintended consequences with every pivot on the payment policy. And what I don't want to see is quote unquote reform. And it's not just me, our entire movement, certainly the National Alliance for Care at Home and all the people within the Alliance family, we want to see reform mean more care, better care, save the system resources. What we don't want reform to be is either intentionally or accidentally decimating the program. And we've seen that in health policy before. When people get down the wrong road, even with home health, all of our members in the Alliance that are in the home health world know we were just recently implemented Medicare home health payment reform. It was supposed to be a modernization of the home health program. It's actually led to billions of cuts because the payment model was not tested before it was implemented. There was no piloting of it. It was something that was done just on somebody's spreadsheets or PowerPoint presentations and thought it looked good. It's led to millions of less visits, tens of millions of less visits, billions of dollars of less resources in home health. So that's not the story we want for hospice. Hospice has to be treasured, and that's the launching pad for conversations about reform. I want to point one more thing. I know it's getting. I can sometimes be like a train going down a hill without brakes.
Don't worry, I'm
on
here.
some of these topics. It's I think my 17-year-old would say that I'm like melatonin when I start talking about this kind of stuff. But the one other point we got to make about hospice payment in Medicare, and then we'll move on to another topic, is that it's all within the traditional Medicare program. Okay, so we know Medicare beneficiaries have an option, and more than half of them are in the Medicare Advantage program, in the private Medicare plans. But right now, private Medicare Advantage is not part of the hospice program. So people, even if they're in a Medicare Advantage plan, traditional Medicare pays for hospice. And I would say also one of the reforms that will occasionally get floated is, well, let's carve in hospice to Medicare Advantage. And for many, many reasons that we can get into or save for another episode, Elyssa, it's not going to be the right thing for Medicare beneficiaries.
Yeah, absolutely. There's a lot to talk about there. I want to focus on one thing that you said around kind of the early part of the hospice stay, where the additional stress on the providers themselves to transition the patient, on the family, of course, and some of the ways that increasing length of stay would help alleviate those burdens over the long term, would help with even workforce burnout, would help with the patient outcomes and the patient satisfaction. And so there are a few different avenues into that. One of them is thinking about the prognostication requirement that we currently have and what changes we might want to see there to help incentivize patients into care earlier. I think one of the challenges that you can probably speak to from personal experience is that oftentimes physicians feel like they're giving up on their patients when they're referring them to hospice, so they don't even want to make the referral. And so hospice providers try to build relationships with the communities that they serve and to educate providers and community members alike to get hospice at the right time, but that's just not happening. And just one more piece that dovetails with that, concurrent care. So like you said, patients feel like they have to give up care to get hospice, which we know is not the reality, but why force them to make this choice when we don't have to necessarily? Like, what are the different ways that we could think about changing the prognostication requirement or enabling concurrent care into the hospice benefit to better serve patients and families, to potentially help move that length of stay a little bit longer, which we know, again, provides better outcomes for patients and families and reduces burden on the workforce and saves the system money.
Yeah, I mean, I think that area that you're zeroing in on of prognostication is of critical importance. Of course, the model in the current hospice benefit is 6 months or less, that if the illness runs its usual course. Some conditions, we physicians are better at prognosticating than others. I'd say there's one I would just want to highlight that I think some type of exception or other model needs to be addressed, which is around dementia. Okay, Alzheimer's disease, Parkinson's associated dementia with Lewy bodies. they have a variable course. And we've seen that people with late stage dementia, they sometimes take a different course than we're expecting. They live longer in hospice occasionally. You provide them with tender, loving care, focus on the basics, and they end up having longer stays in hospice. Actually, lots of hospices have gotten audited around their care for people with dementia. And there's been a lot of scrutiny. Are they trying to, get people in earlier than they're eligible for? Or is this causing, too much payments to hospices? Also, a lot of people with dementia, because of that, end up getting discharged from hospice alive, even though they want and their families want continued hospice care. And I think it's a tragedy. I think in this country, in 2025, if somebody has terminal dementia and their brain is failing them and they have all those needs and their family has those needs, that they would get discharged from hospice because of the hospice is scared that they're going to get audited in one of these systems. Something has to change in that degree, and that's important. Now, broadly speaking, getting people in earlier in some of the issues you talked about around the physician reticence to refer. There's so many ways to improve that. Now, Medicare Choices model, that was a demonstration program done within Medicare where that wasn't focused on prognosis so much as the care goals. So what Medicare Choices allowed to happen is someone who's continuing to get active treatment for sort of from a curative approach. Maybe they're continuing to get chemotherapy for a cancer diagnosis, that they would be able to start hospice-like services while still receiving some of those therapies. And so they have to have that prognosis, right, the poor prognosis, but that they could start in hospice care while still receiving some treatment. And that makes it a more natural transition, that people, it's not like a light switch. Today, I'm focused on curative care. Tomorrow, I'm focused, we're only comfort care today.
Right,
that's
real
not
continuum.
that's not a natural transition. The Medicare Choices model gave beneficiaries an opportunity to make that a little more smooth. And you know what happened? People had better care outcomes. They got longer lengths of stay in hospice, and the overall cost of the system was lower. Expanding this model is something that should have been done yesterday. If anybody in Washington is looking for low-hanging fruit to improve Medicare,
listen up.
Improve Medicare, lower cost, this type of concurrent care model within hospice is one of the first things they should be looking at.
Yeah, absolutely. It actually harkens back to creating the full continuum. Like that's what we're trying to do here in Care at Home. There's a lot more that we could talk about. We touched a little bit on flexibility for respite. I talked a little bit about how hospice providers are already supporting the communities they serve with bereavement support, and we could potentially think about building that into the model and something else that providers are reimbursed for. We talked about the workforce strains and how it's critical that we have that support. One other thing that could help support the workforce is telehealth flexibilities. If you want to briefly touch on that. And then one thing I really want to make sure that we talk a little bit about is rooting out bad actors and how we can be effective in our oversight.
Yeah, telehealth is critically important, particularly for physician and advanced practice nurse services within the hospice program. There's only so many primary care, geriatric care providers in the country. And some of the hospice assessment, some of the administrative tasks that have to be done in certification, they can be done using virtual care, a video conferencing interaction. And fortunately, actually, Congress just through their continuing resolution to keep the government open. I don't know what do we do it for a few days this time or a few? I don't know. It seems like we only like to keep the government open for a few months at a time.
Yeah, we'll be back here soon.
But where we got on that, I think through to September. Is an extension of hospices being able to do the certifications through telehealth. And so, we've just got to make that an ongoing part of the program. No question about it. And, one piece in this reform topic that we didn't get to earlier, just the care for special populations, okay? Let's not forget about people that have dialysis or end-stage kidney disease. The current hospice model doesn't work great for people with kidney disease, and so we need to find a way to change the payment structure at some point to incorporate people with those type of care needs. But of course, going back to your other point, one of the big topics in hospice is trying to keep out bad actors, okay? Because it's a home-based model, because it is primarily about teams. There, in some states, there have been low barriers to entry, and some people have set up sham operations. We've seen this. Listen, fraud, and if we're going to talk about hospice fraud, we have to point out for sure that fraud and abuse in Medicare cuts across all provider types. We have crazy schemes and scams that have screwed the Medicare program, whether we're talking about last year there was a big catheter scam, and we've had things around drugs and devices and physician billing and upcoding. We've even got Congress now talking about what these Medicare Advantage plans might be doing with coding in some instances, which is a tragedy. And so the whole system, listen, it needs to be policed. It needs oversight. When you're going to spend $1 trillion a year, somebody's got to mind the shop. All right, hospice, we've seen, California, we saw 1,000 hospices pop up in a couple years in LA County, even though there was really no clear need for that many more hospices. Some of these operations were all operating out of the same address. Some of them, by the time the surveyors find them, they've been shut down, and you can't find the people who are responsible. And so that type of activity has to be squelched. I've got to think with AI analytics, that identifying a sham operation, people that are billing for something and not providing the care, or are using a really cynical business model, that can be rooted out using analytics in some way and really diving in. And also we need more surveys. I can't remember who said it, but one of our hospice leaders pointed out that one of the most scary things for a fraudster in this is a nurse with a clipboard. Okay, we need nurses in the field that are doing survey work. Medicare is behind on their survey. They are supposed to be doing many more surveys than are being done right now. Just show up at the door, get ready to do an assessment of some of these programs, and make sure they're doing what they are supposed to be doing. And the National Alliance for Care at Home, we are fully behind getting rid of fraud and abuse within hospice, within home health more broadly. Our members, in order to join, you need to attest to certain quality and compliance standards. We want everybody in this care at home movement a part of the alliance, except for people that want to abuse the system. That's actually people that we'd like to see shut down. Now, all this said, when Medicare creates new audit programs, they don't always get it right. And sometimes those programs, it seems like, are focused on where a contractor can somehow squeeze more money out of an established provider than actually trying to find the people that are committing crimes against the program. And so we've got to be vigilant, both to make sure that we don't lose track of how to stop fraud, and at the same time, we need to make sure that these anti-fraud measures are not used to prohibit access to care for people that need it.
Absolutely. And I know we've talked a lot about that in the Alliance with regard to the Special Focus Program and how its flawed implementation risks preventing care from patients who need it and identifying hospices that are not poor performing as poor performing, while at the same time missing those that truly are poor performing. So there's a lot of work that needs to be done. What is it, like the scalpel, not the sledgehammer analogy, to make sure that we get that oversight right, to get the bad actors out, and to focus our improvement efforts on quality providers who are looking for that additional support. But one kind of point to underscore as we close this segment is that the vast majority of providers are providing high quality care. So you see the headlines about fraud in hospice, or like bad actors in hospice, or poor quality special focus program. That is not the vast majority of providers. And hospice already has a reputation problem. We talked about saying the word hospice being a buzzkill in any situation. We need more positive stories about hospice, and to help the American people understand that hospice provides a benefit to them and is not something to be scared of. And so when we have these conversations about bad actors, it's important that we're clear that this is not the vast majority of providers. Our benefit has been a success, and we are continuing to push that forward. We've been lucky in the last couple of years, despite a lot of negative headlines about hospice care to have, the amazing vulnerability that former President Jimmy Carter and his family shared in telling his hospice story publicly, and to get more people telling stories like that, starting conversations, really help us, because if we can talk about it, then we can start to get at some of these issues that we've talked about today. Again, all well, not letting our finger off of, or not letting our focus move away from the bad actors, and making sure that they are removed from the program.
You got it, Elyssa. And the I'm glad you brought up President Carter's hospice story. It's an incredible, example of a longer stay hospice patient getting great care, being able to stay in their home with their family. And it made, from the comments the Carter family made an incredible impact on the last 19 months of President Carter's life. But this conversation, hospice is a success story, right? It's not a runaway cost center. The payments for hospice as a proportion of overall Medicare costs have remained relatively stable, and in many instances, it's saving the system money. So in spite of some of these problems, it's a success story. And I hate to be cynical. I'm going to tell a little cautionary story here. Because I think it resonates. I'm old enough to know of Meredith Willson's musical, The Music Man. Okay, this is the story of Harold Hill, who's a traveling salesman who comes into River City, Iowa. Okay, and basically he wants to sell the children of the city band equipment. His whole scam is that he's got to do something to sell the families and the parents uniforms and equipment to start a band for the children in town. By the way, they all pay up, but the equipment never comes. But that's another story. But the whole issue is that what Harold Hill did was he explained that we got trouble in River City. Okay, trouble in River City. That the kids are playing pool. There was a pool table put in the town, and so now, the kids are going to become delinquents, and they're not going to go to school or church, and the whole town's going to go awful. And he's got a solution, right? He's got a solution. And one of the things we got to be mindful of in this discussion about some of the things that aren't working in hospice is that Music Man story, where somebody wants to come in and I've got a solution. Okay, and when we're talking about carving in hospice to Medicare Advantage, even though Medicare Advantage, it's got a lot of great things about it, but it has not worked well in home health, and it needs to be optimized. Putting prior authorization and denials into the hospice mix would not be good for beneficiaries. Even some payment reforms, if it's payment reform that cuts care and reduces access, that's not a good story. Or we'll hear people trashing certain types of hospice providers and their colleagues and the hospice across town to try to get a competitive advantage, right? And so we have to make sure that we talk about hospice as it is, which is a national treasure, that we talk about hospice as it could be, many opportunities for improvement, optimization, and that we avoid risking going down paths that ruin it.
Yeah, that's a perfect note to end on. We have a good benefit as it is. There are potential pathways forward, but we have to be cautious of a solution in search of a problem.
Yeah. In Washington, you've got a lot of that, Elyssa. The solution in search of a problem, no doubt about it.
This show is brought to you by the National Alliance for Care at Home, because everyone deserves access to high-quality care where they feel safest. The Alliance is working to advance policies, support caregivers, and shape the future of home-based care. Visit allianceforcareathome.org to learn how we're driving change and you can get involved. All right, let's get back to the show. Okay, for this next segment, I'm going to read off a potential policy area, and you're going to say, do we keep it or do we toss it? Policy number 1, increasing audits of eligibility documentation.
Yeah, toss it. We don't need more audits they're just paperwork initiatives. The burden associated on the audit front has been immense. And a lot of times what we find, most of the time, that the good providers, at the end of the day, they prove themselves to have had the right documentation and done the right thing for the patient, or maybe they had, a bit imperfect documentation. It becomes an exercise like in documentation rather than about good care. I think there's a lot of other ways to improve the system than, an avalanche of new audits.
Absolutely. We don't want to divert precious resources towards that could be used elsewhere, we can be more effective in our oversight. That leads me to policy number 2, expanding concurrent care, allowing some treatments alongside hospice.
Keep that. I mean, concurrent care is one of the big opportunities in hospice reform. This would mean, again, let's just reiterate, concurrent care would mean allowing people that are still getting active treatment or curative treatment, if you will, for certain conditions to start hospice-like services, that team-based care, that patient-centered comprehensive care plan earlier, getting to know the hospice team, getting that family support. And that's going to get people, we know this from the Medicare Choices demonstration, it's going to get people into hospice care earlier. It's going to lead to better outcomes and lower costs. So concurrent care is something that should be at the center of conversations around hospice reform.
We love a win. Okay, back to oversight for policy number 3. Increasing oversight on hospice providers to curb fraud. Kind of painting with broad strokes there, but keep it or toss it.
We've got to keep it. Okay, this is a movement that is all about serving people and serving society in an ethical way. There do have to be ways to police this program so that bad actors are kept out. One of the key areas of focus has to be Medicare ratcheting up their survey intensity. They're not doing the number of surveys that they're supposed to be doing, and we need those nurses out there in the field showing up unannounced often to verify that the agencies are doing the right thing.
This last one, I feel like we kind of answer it in the policy statement itself, but still worth talking about. Can't ever talk about it enough. Adequate reimbursement rates to enable providers to stay competitive in their care team compensation and address workforce shortages.
Yeah, we got to have that. What people have to think, okay, listen, nobody got into this, just from getting to know you, Elyssa, just and all the people that I meet in hospice care, people are in it to help people. And anytime we start talking about money, people feel a little bit uncomfortable. It doesn't feel like this is our purpose, right? We're here to help. And so reimbursement conversations, they sometimes feel like, maybe a little sharky, or that it's not, we're not focused on the patient. But the bottom line is what those reimbursements represent is care. They represent talent. There is no way to provide that type of love and skill and reliability. Hospice happens 24/7. Okay, this isn't something like people don't get terminal shortness of breath during banking hours. Okay, they need care in the middle of the night sometimes at home. On the weekend, we need a workforce that has both the skills and the talent to do this, the availability, and that means the payments at least have to keep up with labor cost inflation, or else people are going to get less care. It's simple math.
Yeah, you're absolutely right that people do kind of clam up when you start to talk about payment in hospice, but a wise woman once told me, no money, no mission. So I think that can undergird all of our conversations. We're doing this for the right reasons, and we need to be able to support that care. So I think that's the perfect place to leave it. Hospice is at a crossroads, and the decisions made now will impact families for decades to come. If you want to stay informed on these critical issues, make sure to subscribe to our YouTube channel. Just search for Who Cares or the National Alliance for Care at Home, tap that subscribe button, and you'll get new episodes, insights, and the latest on how we can reshape care at home together.